Casey, if you want to go ahead and start recording, that'd be great.
You're live.
Good evening, everyone, and happy Thursday. Welcome back. Thank you so much for being here tonight. As you know, as you've probably seen all my emails, tonight we're going to be teaching something called Triage, which is not part of the national CERT curriculum. It is something that we do here in the Bay Area, all the CERT programs here in the Bay Area and throughout California. California has asked for Triage to be included in the curriculum, and that's in the process right now. So you guys are getting it ahead of the curve, if you will. But it's something that we've been doing routinely in our program for years. It is what professional responders use, and it is our ability to be able to converse with them in a language and a system that they're familiar with, and we can speak to each other. And Triage essentially is a process to help you walk through something that is very difficult. Traditionally, triage is the concept most difficult for those of us who are not medical professionals to really wrap our heads around. So I want you to remember a couple of important things. First of all, this is in a catastrophic disaster situation. The skills you learn in CERT, including in triage, may help you in day-to-day stuff. But this is not the reaction or the response you would do if a coworker collapsed from a stroke or a heart attack, or if a child fell and broke an arm. This is not that. This is in a disaster situation where professional responders are stretched thin and having to respond to major issues, and you're having to deal with this particular situation where there are more victims than there are responders. And remember, you are the responder. All right. All right, Pauline is back with us this week, and she'll be helping us out. And one of the first things we wanted to do was to respond to some of the terrific questions you had last week that we wanted to do some research on and get the latest on. So Pauline is joining us again today, and she has done some fantastic research and looked into this for us. So take it away, Pauline.
Hi, everyone, and welcome back. I've talked to several different people and looked it up on the Google machine, all the questions that you had. And they were great questions because it tripped up a lot of people up to the doctor level. So let's start with the question about the cap refill in children. From what I gather from paramedics, EMTs, doctors, they all say we don't use it in children because it's unreliable. And they think it's because children decompensate so much faster than adults. If you can see this line up here, an adult will go down slowly as he's getting worse and worse and worse. Whereas a child will be up here and then boom, go down really quickly. So that's why they think that cap refill is not the way to go for children. What you should do to check the perfusion of a child is use a pulse check. And for children, the best one is the brachial artery. And I think you had a sheet that Sandra sent you this week that showed where the brachial artery is. And it's just in the inner upper arm. And you push against the bone and you'll feel that pulse, and that's the easiest way to get a child's pulse. The other thing was the temperature of the water for frostbite. So that's all over the map. The doctor told me 100. I heard on Google it said 105 to 110. EMTs thought that was a little bit high. And I think the information that you got this week said 105. So I would say between 100 and 105. But here's the other thing. Are you going to have a thermometer that you can test the temperature of the water when you're out in the middle of nowhere and you need to put this guy's frostbitten foot in some water? What I would do is get the water to a comfortable temperature, stick your elbow in it, and if it feels okay to you, then that's okay. You don't want anything too hot because that person can't feel their limb. And if you put say their foot in that water and it's too hot, you're going to burn it. So start with something that's comfortable that you can put your own arm in and go from there. Are there any questions?
No questions so far, but
Okay.
we've got some few people laughing over the fact that they couldn't agree on the temperature.
Oh, okay.
Yeah, so extremes of any type, that's what we're trying to avoid, right? So again, if it's comfortable to you, bath water, just like you would check for before putting a child in the water, same thing with somebody with frostbite before you put their frozen limb into water. So again, avoid extremes. All right. So let's start off with a poll. See how awake we all are tonight. Casey, if you want to go ahead and throw in that poll. What are the 3 killers? What do we remember from last week? You have a couple of choices there. Keep going. I'm waiting on a few of you who are still deciding.
We're almost there. We'll be closing in a few seconds.
Okay. There we go. Terrific. All right. So nobody went for my airway bleeding and swaying? No? Okay. So the second option was airway, broken bones, and shock, which is close. But the actual answer, the 3 killers are airway, bleeding, and shock. Those are the 3 things, the priority things. And here today, when we talk about triage, you're going to see how that actually works. Again, it's a system to help you make decisions in a very difficult situation. So airway, bleeding, and shock are the 3 killers. So very good. Nicely done, you guys. Let's see. All right, so objectives for today's class is obviously identifying those 3 killers. Conducting triage, again, this is in a disaster situation, right? Where there are more victims than there are rescuers and you are the rescuer. Identify the level of treatment. So we're going to sort them by what their needs are based on what their injuries may be. And of course, treat life-threatening injuries. All right. Now, I want you to, in everything that we do when it's training, there are certain assumptions we have to make. We are pretending. We have no way of knowing what we're going to come across. By the way, have you guys been watching the news today? There's been a little shaking going on, and our friends in New Zealand have been experiencing over at least 3 earthquakes today. I believe the lightest one was a 6.8. And the highest one, the strongest one was an 8.1. These are very strong quakes. Each of those quakes has caused a tsunami warning to be issued all the way to Hawaii and to the West Coast. We are fine, and we've been monitoring. Our friends in Hawaii have been monitoring, and throughout the world, the Philippines as well. So far, no tsunamis, but after an earthquake, in certain types of earthquakes, in this case, I believe it's called a subduction quake. It's where if you think of the plates of the earth, right? One dives under the other one, lifting it up. And if it's underwater, there's water all above that plate, it's got to go somewhere. So now the bottom of the ocean has lifted, a wave forms, and that's how you get a tsunami or tidal wave, right? So, so they've been watching that, and it's been interesting, but obviously our friends in New Zealand are going to need some help because there has been a lot of damage. I haven't heard of any deaths or injuries as yet, but I haven't been watching the news consistently. But there has been quite a bit of damage, infrastructure, roadways, that sort of thing after these earthquakes. In any case, getting back to training, that's real life. We train with the hope of being ready for whatever the situation may bring us. So in this case, the assumptions are going to be that there are Again, more victims than there are rescuers, and that survivors, some of those people who are not as badly injured, will be willing and able to help you. So you can utilize them as a resource, right? Now you should have watched the start video, which was on the home base page. I hope you were able to watch it, because that we'll be referring to that throughout the course of the night tonight. And there are some things there that we want to point out to you. Any questions from what you saw last week as far as Medical 2, Unit 4, or from the start video right off the bat? Anything right now that you want to ask? Okay, no worries. So I'm going to let Pauline take over from here, and we'll be playing tag team throughout the night. And of course, any questions that come along, pop them into the Q&A box and we'll get rolling with them. All right.
Okay, so you probably all heard MCI, that's Mass Casualty Incident. And like Sandra said, that's when you have more victims than responders. So, for instance, on the bus, there was a couple of guys outside the bus who were taking care of things outside with the car and everything else that was going on. But the one responder that went in the bus, and there was about 10 or 12 people in the bus who were patients. So 1 to 12, he's got to go through all of it, all of them, see who needs the help the quickest and who can wait. Sometimes it's hard to tell, because the screamers, the people are screaming the loudest, are usually the ones who are not hurt the worst. So you have to go through this a little bit scientifically, and if you follow the program, it comes out pretty well. But you have to keep track of your people also. You can't just say, okay, he's okay, I'm going to tag him with a green tag, and then just leave him alone and not have anybody watch him. So everybody has to be kept be watched.
Hey, Pauline, we did have a question that came up.
Uh-huh.
So it seems that the online learning contradicts itself in a couple of places regarding moving deceased victims. So do you have anything to say about that?
Yeah, we don't move deceased victims. They obviously don't need help right away, and you have to take care of the people who do need help right away. So we do not move them. We let the firefighters and the coroner and those people take care of that later.
In our county, the coroner has ruled that any person who is considered deceased, that is now a crime scene. So we never remove someone that we suspect is deceased. The coroner is the only one who does it.
Okay. They also clarified their question by saying it talked about a morgue in the treatment area. Yes. So it's just a professional to move the bodies is what.
No, the morgue in the medical treatment area is for the people who die after they've been put in the medical treatment area. So if someone is brought to, an immediate is brought to the medical treatment area and they die while they're there, they're moved to the morgue.
And that's done by whom is what I think they're trying to get at? Is that done by CERTs or a professional?
It can be, yes. Whoever is in charge of that area.
Okay, and we had another question that came in regarding the earlier question about perfusion in kids. Up to what age would you consider the max for a brachial pulse option?
Well, you can use a brachial pulse option in anybody, but I would say probably up to the age of 5.
Thank you, Pauline.
Okay. Mm-hmm. So what we're going to do when we're going through is to check for airway, bleeding, and shock. Those are the 3 killers, and that's what we're gonna check for. Triage. Triage means to sort, and that's what you're going to do. You're going to sort all these people in the bus, or all these people in this classroom where they've had an earthquake and things have fallen on them. You're going to sort them all into the level of necessity. So is this person able to walk? He can walk out. Is this person immediate, they have to go to the hospital first. So we're gonna tag those people so we know who to bring to the hospital first. And are these other people delayed? They have a broken leg, but that's not life-threatening, so they can wait. So that's what we're doing. We're sorting.
We had a
And
question, Pauline,
yeah.
regarding the difference between contusion and swelling. As in some of the photos that were presented in the lecture, it seemed that the pictures looked very similar. So what they're really trying to get at between swelling and contusion, which is more serious, and how do you tell the difference?
Swelling is a bump. Contusion can be a bump also, but it's also discolored. It's purple or blue or green, usually purple right at first. So contusions are black and blue marks. So that's the difference. But they can both be a little bit of a bump.
And is one of them more serious than the other?
I don't think so. I mean, it depends on where it is, but I don't think so.
All right, thank you.
Okay, so one thing that there's only two things that you're gonna actually treat when you're doing triage. You're not gonna stop and do CPR. You're not gonna stop and wrap a splint an arm or something like that. The only two things you're gonna do is open an airway or put some pressure on a bleed, on a severe bleed. So, and we'll go through this a little bit, but you can use some of your minor people to help you. You did see on the bus that one, I don't remember if it was a man or a woman.
Two people, I think one was a man and one was a woman.
So he opened the airway and he asked one of the minors to come in and help him hold the airway open while he went and finished everybody else. And that person was breathing, so that was good. That person was obviously an immediate, but for the time being, he's breathing, and that minor was helping. Sometimes that's good because it keeps the minors busy, and if they get really nervous, sometimes it gives them something to do, and that helps. So here's a shot of the airway, and we talked about the airway last week and how to open the airway. Do you remember? We can do the head tilt chin lift on our friend over there in a little while if you'd like, but it's tilting back the forehead and lifting up on the chin. Remember, not on the soft part of the throat, but again on the bony part of the chin, because you don't want to block off any arteries in your neck. So head tilt, chin lift, and do it once. If that doesn't help with the open the airway, do it a second time. And if that doesn't help, you're going to mark them dead. And I know that's difficult to do. Well, maybe I could do CPR. Maybe I could give them some rescue breaths. No, because that person right next to them may only need you to do their head tilt chin lift or put some direct pressure on an artery, and you could save their life. Whereas you're going to take the time to work on this person who you probably won't be able to save. That's the difference between your aunt who fell over here and you're one-on-one with them, and a multi-casualty incident. So this picture, I think we've seen this before, but you can see how the tongue, when someone goes unconscious and they're laying on their back, the tongue can go into can relax and go in and block the airway. So what you're doing with head tilt chin lift is just moving that tongue up out of the way. So if that's what the problem is and you're open the airway, then that's great. If the problem is that they had a heart attack, that's not going to help. So that's the difference. Here's head tilt chin lift. So I think we've done this. If anybody has any other questions about this one, remember, don't block the neck. All right, and here we are with bleeding. Now, direct pressure is always the way to start. And if that doesn't help, you can elevate it and you can use a pressure point. So say they're bleeding down here and you can't get it to stop, if you press on the brachial artery, here we are with that brachial artery again, and you push hard enough, that's like a manual tourniquet, and it's going to stop the blood from flowing down there. So if you can get that to stop enough, and you don't, I mean, you could use a tourniquet, but not during triage. But if you can get it to stop doing just by pressing on that artery, then that's great. And then you can continue with the direct pressure. Don't take that off, and elevate it. And you can get your miners to help you if they can sit there and hold this arm up and with the direct pressure on the wound, that's better. A tourniquet, I don't know if you'd use a tourniquet in a multi-casualty. I don't know if you'd have one.
Well, if you had, yeah, you would have enough, but maybe somebody's belt or something.
Yeah, you could use a belt. But remember, use something that's at least 1.5 inches or 2 inches thick. You don't want something that's thin like a shoestring, because that's just gonna make,
Not as much.
yeah. Okay, you've seen these 9 steps before. Remember, before, yes?
We have a question regarding how long would you treat bleeding before continuing with triage if no minors are available to help?
Oh,
Sometimes the victim can.
yeah, sometimes the victim can help you themselves. But yeah, or maybe someone who's right next to them who may have a broken leg, someone who can, who's a delayed, someone can help, but I wouldn't spend more than 30 seconds.
Yeah.
Because you need to get to all the rest of those people. So these, the size up actions here, you've seen this before, and this is really important because you don't want to go into a space and start triaging people when you don't know what's in there. You have to look around. You have to check what may have caused this. Check what has happened after, like when the bus tipped over. What happened after it tipped over? You want to find out what has caught, what danger you might be in if you go in there. So you saw the guy look around, and when after he got that back door open, he looked through to make sure there was nothing else going on. I mean, he looked outside to make sure there was no wires. There could have been some electrical wires or something like that, or that other car might have been starting on fire. You got to check all around to make sure that you aren't getting into anything dangerous, because once you're in there, and if you put yourself in a situation where you get hurt, you're no help to your patients. Start simple triage. So the first thing that you're going to do is, like I said, check to make sure it's safe, and make sure that you're going in with the correct PPE. You should always be wearing gloves, probably 3 sets of gloves, because when you move from one patient to another, if you get anything, and any blood or spinal fluid or vomit or anything like that on your gloves, you need to take them off before you go to the next person, because you don't want to bring one victim's germs to another person. So make sure you have your gloves on. You probably want to have some eye protection in case someone's bleeding profusely and you don't want to get that in your eye. You also probably want to wear a helmet, because things might be falling from the ceiling, and things like that. So make sure that you protect yourself before you go in. And you start where you stand. We always are in threes, so we'll talk about that. The firefighter went in alone. He had some people outside, but he did go in by himself. But we'll talk about if we have a 3-person team, how we might make that work. So like I said, we're going to evaluate the patients and find out which ones need care the most urgently, and then when you get there, if you can, if you see that many people, you're going to probably want to call in to your command post or your ICP and ask for more help, because you can't help all these people, even if you tag them. And that's another thing you could probably call in. How many patients you have, how many are immediate, how many are delayed, and how many are minors or are deceased. And that will also help them after you've triaged, so that they know how many ambulances to send. So let them know you need help up front, and then call them back and tell them what you found after you've triaged the whole bus or the whole area.
Pauline, can you clarify, when do you change the gloves is what they're asking.
If you get anything that's wet and not yours on the gloves, take the top layer of gloves off, because you won't want to give that to the next person that you're treating. If you get down to that last set of gloves and you have another set in your pocket, I'd try and put that one on, because it's really hard when your hands are sweaty. After you take them out of the last pair of gloves, it's going to be really hard to put the next set of gloves on. So just remember that. I've experience. Okay, triage means to sort. That's what you're going to do. And it was started by the military, and for the same reason that we use it today, so that we can report what we need to people who are going to come in and help us. More victims than rescuers, limited resources, and time is critical. Time is critical to some of these immediate patients. So that's why I say 30 seconds with each patient, so that you can get that information to your ICP, so that they can send more responders or more ambulances to the scene to get those people to where they need to go. And we're trying to do the greatest good for the greatest number of people, because we're CERT. So immediates, we have different colors. I'll show you the colors first, and then we'll go to the other. Red. Red is immediate. Red is always just right out there. So that's how I remember it. The red is the most important. So these are the people who really need attention right away. So red is immediate. Yellow is delayed, like a caution on the stop signals. Yellow is, these people are hurt. They can't walk, but they can wait a while. They can wait until after we take care of the immediates. Be careful with delayed. They could change to red, so just keep an eye on them. But initially, they're delayed. Green is go. These people are minor. So these are the people who can help you. These are the people who, when you do your verbal triage at the beginning and you say, if you can walk, come to the sound of my voice, they will come to wherever the entrance of it is. The difference between delayed and minor is ambulation. These people cannot walk. These people can walk. So that's really the only difference. And this doesn't require any explanation. These are deceased. Rescuer safety, we talked about this. A couple pair of gloves, helmet, goggles. It says N95 mask here. N95 mask is important if you think that there's any kind of a respiratory issue. And so it's good to have. If you're going to be real close to people, it won't hurt to put it on an N95. It is a little bit harder to work in that, but if you have one, it's always good to have it. Work gloves are good to have too. It depends on the situation though. If you're working just with patients, you want to have those non-latex gloves on, because it's easier to work. But if you are in a place where there's a lot of wood or some things that have fallen, work gloves are good too. You might put those over your exam gloves. You always want to have a closed-toed shoes or boots, because you don't want to be stepping on a nail or on some kind of something that fell from the ceiling and get that to poke through your foot or drop on your toe. So the best, you should always wear good sturdy boots. Did you have something, Sandra?
No.
Okay. 32 can do. I learned RPM, kind of the same thing. 30. What is 30? You're looking for how fast people are breathing, respirations. You're not going to sit there for a minute and say, okay, go. No. If you are with somebody in there, that's too fast. That's not normal breathing. That's over 30. You don't even have to go any further. You don't have to sit there and count. You know, it's over 30. So if they are over 30, then that means they're immediate. 2 is the cap refill. Cap refill should come back within 2 seconds. If it does not, then they're immediate. So this is a real quick thing, but again, we talked about if they have nail polish or you can't get to, somehow you can't get to their fingernail, you can use this part of the hand. I don't know, can you see that? This part of the hand, and just the same thing. The redness of the blood coming back into the hand should come back within 2 seconds. So, so 2 seconds for perfusion. And can do is mentation. Ask them a question you know the answer to. Ask them to follow a command. If they don't, if they look at you like, what? Maybe they don't understand English, or maybe they can't hear or speak. So you kind of have to work around that. Sometimes if you just put your hand out to somebody and they'll like you're shaking their hand, they'll grab it. And then if you squeeze it, they'll squeeze back. So that can tell you that they understand, they following commands. But most of the time you can get someone to say something. But if they seem confused, like, where are you? I'm at the park, but they're not at the park. Or they're, what's your name, grandma? Or, you know, something like that. They just say something that just doesn't sound right. Ask them another question. And if it still sounds that way, mentation is not good. And you're going to mark them immediate. Those people are going into shock. They're not perfusing, and they're going into shock. So those are your 3 killers.
Pauline, we have a couple questions that came in.
Okay.
So do CERT volunteers need to bring their own PPE?
Yes. Yes. And you need to change your gloves on occasion. They will get a helmet. Helmet.
Okay. Do you want me to do-
Yeah. Because I'm not.
So if you are one of in our 3 cities and you're going to be in our program, once you've completed CERT and your skills day, you will receive the basic CERT backpack with some basic equipment, which will include your helmet, a pair of goggles, a pair of work gloves, the multi-tool, the CERT vest, the lovely vest, and so your basic things. We also try and throw in at least 1 mask and some gloves, but then that's up to you to certainly replenish or decide if you want to carry more than those. Next week, let me make sure next week you're going to meet another CERT member, and he's going to show off his backpack that he's put together over the course of many years in CERT, and you'll be able to see some of the things that he's decided to carry. Everybody's CERT backpack is slightly different, but most have certain consistent things, and certainly the vest, the helmet, the backpack, eye protection, and gloves are among those. And so it's up to you. Once we give these to you, then it's up to you to obviously replenish anything that you use and build up the backpack to your liking based on experience and other people you've talked to.
And Sandra, what resources will be available at the incident command post when they respond?
Great question. And I was going to sort of, let's do that now. Okay, everybody settle down. So let's imagine that something like what happened to our poor friends in New Zealand today, an 8.1 earthquake hits. Oh my God. Okay. And you are a CERT member. So what do you do first? Take care of yourself, take care of your family and your home, and your immediate neighbors. Okay, so you're going to be checking, making sure everything's okay, check your house, check yourself, sort of do a quick inventory on the situation, right? When you get everybody settled, everybody's safe, you've decided whether the house is safe to stay in, they have water, you have what you need, your neighbors are in good shape, maybe you know somebody down the street who just had surgery and maybe having mobility issues, go check on him or her. All right, you've checked on that. And then in that time period, you've received notification of some type that CERT has been activated. Our CERT program would activate, we don't automatically go. So we have to wait for word from above. So we activate our CERTs under very specific situations. One, our professional responders have to be stretched thin to a point where they need the extra help. So the activation could come soon after the incident or days after the incident, depending on what the incident was. And then it has to be within the scope of our training in CERT. So we're not going to go have you put out structure fires because that's not what we train for, right? But we might have you set up or assist at a medical treatment area. Very reasonable situation, right? We have victims coming in and we have them categorized. So let's imagine, right? You've settled your home affairs, your family is safe, your neighbors are in good shape, and CERT has been activated. So then you would go to your neighborhood meeting place, for example. In the activation, you'd be told where you'd be going. It could be your neighborhood meeting place, or it could be another place that we've decided we need more CERT's assistance at. But let's just say it's your neighborhood meeting place. So once you've become a CERT member, you'll know what neighborhood you're in and where those meeting places are. And then you would walk there. As you're walking there, right, you're taking note, documentation of houses or buildings, places that you're passing up. Okay, you're not, if you see that there's a situation with a collapsed building, you're not running in there by yourself. You're taking note, address, location, possible gas leak, collapse. This house doesn't have any damage. This house, though, is off its foundation. You're writing this down, address and what the situation is. Very brief, but you're writing it down. Then you arrive at the park. All your other CERTs are also arriving at the park, right? And right now, your incident command post is maybe a picnic table and the 5, 6, 10 CERTs who've arrived together. All of you will have some information based on what you've seen as you're arriving. Okay, then one person is going to become the division post leader. Usually the first person who arrives, they're it. But if someone else arrives and has more experience and you wish to hand over that responsibility, you can do so. We'll discuss that later. In any case, if there are enough people to put together a team of 3, then you can take a look at what incidents you have, the collapsed building, the gas leak, whatever it may be, and decide where is it that, what are the priorities, right? How can we do the most good for the most people? Was the building that collapsed a community center, which was empty because we're in COVID times and nobody was there? Then it's not urgent. Was it in the middle of the day during a party and there's maybe 20 people in there? Now that's become a priority, right? Because more people. So that's decided quickly. If there's anybody who's a ham radio operator or has some communications capability, they try to contact up the chain to the emergency operations center, let them know that a command post has been set up at such and such a park. We have enough people to make 2 teams, and we're sending 1 team to the community center and 1 team to this block where we heard there might be some, gas leak. There was smell of gas, and they're going to go check it out. right? And then those teams stay in communication with the command post. And if you arrive to the community center and find indeed there were 20 people and it is collapsed and it looks like you're going to have a multi-casualty incident, you're already calling back and going, we're going to need more people. And they may pull that other team who is just going to look to help you, or more people might have arrived. And then they'll set up that team and they'll say, go help team A over at the community center and do that. In the meantime, everything is getting written down. And even if it's on binder paper, it's getting written down. Okay, I know that's the hardest part. It's a pain in the butt. I will admit it right here. But documentation is crucial, because I don't remember, what I did 5 minutes ago, and certainly not in a crazy situation like this would be, right? You're not going to remember what time it was you did something 4 hours from now, 10 hours from now. So write it down, the time and what it was, right? Possible gas leak, 305 Main Street, 2:30 in the afternoon. But you wouldn't say 2:30 in the afternoon, by the way. You'd say 14:30. We'll use military time. So there's no confusion later on. Again, that's how it would set up. If you have a chance, and I think you'll see it a couple of times in the home base page, there's a video called CERT in Action. I love that video because it does give you a nice picture of what a situation would be like. The only thing that is perhaps different than how we operate is there was no indication that they had been activated in that video. So we would wait for an activation before we left our homes. But it does give you a very good overview as to how things would come together and how they would work. So what resources you have at the command post depends on what people brought with them and how far into the incident we are. Eventually, at some point, perhaps, we have great resources. We have trailers that are available for CERT, set up specifically for CERT, but someone has to go get that trailer and tow it to a certain location, right? And if there's, like, if you take a look at video out of New Zealand and there's streets that are broken and, sinkholes that develop, whatever, you may not be able to get a trailer to that location. So you're going to have to deal with pretty much whatever you've got, whatever you brought with you. And then eventually you'll have more tools and more things to deal with. But again, the important thing is triage, right? You're triaging, you're prioritizing, you're doing your size up, and you're constantly deciding what are the more urgent things, what can wait, and what tools do we have to select which ones we can help the most people with, all right? Triage is the same thing. It's not, triage, you've seen it in action. If you've ever been to an emergency room, the first person you come to is the triage nurse, and that person's responsibility is to decide whose case is more urgent. They're not taking you first come, first serve in the emergency room, right? And you may have somebody who seems to be bleeding profusely, and oh my gosh, and they've got 15 bandages and they're all, holding their arm together. And then somebody walks in and looks a little queasy and they're taken in right away. Well, they're probably in shock. So shock overrode the person who was controlled bleeding, but still under control, right? So the nurse has to make those split-second decisions on who needs to be seen more urgently. And so same thing with us in terms of triage. So you're working, let's say, the bus incident, right? First thing you would do once you open the door and you take a look at your situation, you would call out. You would do a verbal triage. You do this, not in a whisper, not in a quiet indoor voice. You're gonna be loud. You're gonna yell. You want the person in the back of the bus to be able to hear you. Remember, it's going to be loud, it's chaotic. People are screaming, crying, scared. It's dark, it's dusty. Things can be falling, more glass can be breaking. A lot's going on. So that's why you need to sort of step back and assess and make a plan with your team before even going in. But at the door, you're going to call out and say, hi, I'm with CERT. We're here to help you. If you can hear my voice, walk to me. right? You're going to say that a couple times throughout the course, but you want to get people to start walking to you. That immediately is your first triage, right? That immediately sets you up for who your greens, minors are going to be. Every person, regardless of their status, every person you see gets something, some tag. What if I don't have any ribbons? Write it on their forehead, okay? These colors are standard. Professional responders use the same color as we do. It means the same thing to them. That's why we do it. So again, it's consistent up the chain. When this person gets to the hospital and there's a green ribbon on them, they're gonna know, okay, this person can wait a little bit. Let's take the reds and the yellows first, right?
Hey, Sandra, we got a question about that.
Yeah.
Where do you tag the person specifically? So is it an arm, a leg?
Okay, so you don't want to do it on any outerwear like a jacket or something because jackets tend to come off. A lot of people will do the wrists. I like to do it as high up as I can because people tend to look at each other's faces. So higher the better, but wrist, arm, upper arm is the best. Certainly not the leg or the ankle if you can avoid it. But you want to tag them somewhere, and you want to tag them every time that they are triaged. So the first time through, people are walking out, you are tagging each of them green right away. Why do you have to tag even the person who's fine? Any thoughts? Because then you're sure that that person at least has been looked at once. You want to make sure that everyone has been looked at least once. The next person who sees them knows that they've been seen at least once. And remember, you're not going to be the last person to see them and decide. You're not making the final decision. Okay? So don't worry, right? Make a decision. This person's a red, this person's a yellow, this person's a green. And if they're green and they're walking out, they walk out. But do they walk out and walk off into the abyss? No. You've got another team member out there who's going to corral those people in one section. Everybody sit down here on the curb and keep an eye on them because people might, be, faint. They might pass out. Their situation may change. They may walk away. They may be disoriented. They may decide, oh God, I got to find my brother. Where's my brother? And they're going to go off. No, you don't know. Everybody stay here. We'll help you find your brother. Stay here. Keep everybody together. Even in the case of the firefighter, he had a team, his crew was with him. And so they are accustomed to working together, but we work in teams of 3, and a second team in the case of a mass casualty incident would be assigned as soon as another team was available. Yes, I'm sorry, there was another question.
So I was going to add that you might also want to mention the tarps, but we do have, after the tarps, we have another 2 questions, one being, where do you get the colored tags ribbon from?
Okay, so we do have some of these in our trailers, but like I said, the trailer may not get there right away. If we suspect a mass casualty incident, we would give a team going out to a potential mass casualty incident a bag of supplies, which would include triage tape, as we call it. But these tapes are actually not terribly expensive, and they are available they're called surveyor's tape. Surveyors use them, and you want to get them in the appropriate colors: red, yellow, green, and black. And then and you'll see this in Heyman's bag because he does carry them. They'll get all these rolls of tape. Hold on, if I can get the black one here. And then they'll put a string through it or a big carabiner through it and attach it to their backpack. So that's how that works. For professional responders, and you saw this with the firefighter, let's see if I can make this. They use these special tags. These tags are actually quite expensive. They're very elaborate, but essentially they tag each person. This is where the term tagging someone comes from. And this would be marked, but these are, do you call this?
Perforated.
Thank you, perforated, that's the word. So these are perforated so they can pull off and leave whatever's on the bottom is the status of what they are. So here it says minor, delayed, immediate, and morgue, being dead. So if they're immediate, I would fold this back and I would rip off everything and leave immediate as the bottom tag. The red tag would be the bottom of this tag, and then immediately they would see the category of this person. These are very expensive, which is why we don't use them. But if you don't have triage tape, you can write I for immediate on someone's forehead, delayed, D, right? If it's dead, you have to write the word. Do not put D for dead. D is delayed. And I recognize that it would be very difficult. It would be difficult to have to decide that someone's dead. You are not the coroner. You have not declared this person deceased. But if you open their airway and nothing's happened, and then start again, reposition, reopen the airway, and still nothing happens, unfortunately, we don't have the time, the wherewithal, and there are other people, as Pauline mentioned, that might need some minor help to live, to survive. So in a situation like that, the decisions are very difficult. And that's what triage is for. It's, again, a system to help us make these decisions under difficult circumstances. And again, this is a major catastrophe, catastrophic situation. 911 is not available to be there in 4 minutes the way they are now, okay? That's where we are, catastrophic situation. Any other questions on that?
So Sandra, I was going to mention, and you can probably add to it too, but in the ideal scenario, we would have 4 tarps set up with different colors, and that's where we would locate people to. So going back to what you said, that we wouldn't let them wander off, I just want to mention that usually we would have tarps. Ideally, there are 4 different colors, and that's where you'd send people, and that way you can move them from each tarp.
Okay, so here's a photo that I put up there. That's a medical treatment area. So now keep in mind, you're doing triage in a room, in a building, in a bus, in a train, right? And you've tagged everybody. So you've got your greens probably outside, or a couple of them helping you inside. You've got reds and yellows inside. So now you come out and you've got a report. How many do you have of everybody? Okay, I've got this many reds, this many yellows, and we need to, perhaps in the case of a bus, remove them, right? Evacuate them. And hopefully by then, your CERT command post will have had another team. This is not the responsibility of the first team. Another team set up a medical treatment area. So a medical treatment area in a perfect world will have tarps that are the colors that match the tags. So you'll put all your yellows on the yellow tarp and reds on the red tarp and so on. And then there's a team there that is in the medical treatment area, and they are monitoring. So they have 2 people monitoring the red tarp, and 2 people monitoring the yellow tarp, and 2 people monitoring the green tarp, because those people can change in status, right? And that's where we would be treating them. That's where we can splint an arm, or have someone put more pressure on that bleed, or whatever that person needs, okay? But that's the decision. So the decision that when we triage them first and we tag them first, it's how quickly are we going to get these people out? Obviously, the folks who are tagged red will be moved out first, and those yellow will be moved out second, and so on, okay?
And Sandra, that's a good segue into the question we got asked. How do you handle a person you discover already tagged needs to be upgraded or downgraded? Do you keep the existing tag, or do you add a new tag?
Take off the tag. Take off the tag, put on a new one. In the case of an actual tag, if someone is delayed and they move into red, you could rip off the delayed part and red is left over. But if you're using tape as we are, or if you're writing it on their forehead, to avoid any confusion, because imagine the next person who's going to see it is not going to talk with you and get a report from you that, oh, that person was delayed and is now immediate. They're going to see 2 things on their forehead or 2 tags on their arm and not know which is which. So take out the old, put on the new.
I think that's all the questions I hopefully captured. So
Okay, I want to bring Pauline back.
Okay. Does this
sorry,
flow
Pauline,
chart-
we got one more.
Oh, okay, go ahead.
What do you use to write on the forehead? Pen or Sharpie? I'm going to say probably Sharpie. Because pen sounds like it might.
Sharpie would be the best, but if all you have is a pen, you use a pen. But yeah,
Lipstick
Sharpie
and
would.
you have
And that's another thing that, you keep thinking about. One thing more I should put in my backpack.
to-
Paper. I mean, it's simple, but without paper, how are you going to document? And without a pen, how are you going to document? You can't get a stick and write it on the ground. So these little things, you have to you think about it and just keep adding to that backpack. So this flow chart kind of looks kind of crazy, doesn't it? But you will get one of these to carry around with your
ID badge.
ID badge when you graduate. But really, it's just a flow chart, just like you've seen for other things. So just follow the flow chart. Okay, start where you stand, and you have a leader on the outside, and you have your team that's going in. So say you have a team of 3. The leader's on the outside, and he yells very loudly. If you can hear the sound, if you can walk, come to the sound of my voice. Say it a couple of times to make sure that everybody hears you. And you'll see people starting to get up and try and walk over. Some of them are limping, but if they can walk, what's the best way to get them out is if they can get themselves out. So we don't trip over other people trying to get them out. So that's the best way. And even if, when they get out there, you're going to mark them green, right? Okay. When you mark them green, like Sandra says, don't let them go, because they could have an internal bleed and all of a sudden they just faint on you because they're bleeding out. So just keep an eye on them. If you have extra people on the outside, they should be with them. Otherwise, that leader kind of has that responsibility too. The leader also is watching. The leader isn't going in. He's going to send his team in, and they have to decide how to circle the room or the bus or the area. Should they each go separate ways? Should they leapfrog? Whatever they decide is the best after they see the room. So they're going in there and they're triaging along that path. Whereas the leader is outside and he's watching the whole situation. He's watching those miners if he doesn't have anybody else. And he's also watching to see if something's going to fall from the ceiling or if there's another earthquake and he needs to get his team out, something like that. So that leader is really important. I've done triage on our skills day many times, and that leader just wants to get in there and he wants to help his team. But if something happens, he's not helping them. He's not watching for their safety. So the leader is there and he's watching for their safety. So each of the people who are going in and they're doing their triage, they're going to test for respirations. If the respirations are too fast, they're going to label them immediate. If they're fine, then they're going to go on to perfusion, check for cap refill. If that's good, then they'll go on to mentation. If that's good, then what are they going to label them? They can't walk, so they're delayed. They're yellow. But if any of those things, and sometimes you can tell just by talking to the person, and if they can't talk, then they keep going like this. If they can't talk right, something's wrong, and right there you can label them and then move on. And when you do leave them, sometimes they'll hang on to you. They don't want you to leave. They're afraid. Tell them, I'll be back. I have to help everybody else, but we are still here to help you. So just kind of console them as you leave. Don't just get up and leave. So
Elaine, we have a follow-up question from earlier when we were talking about using markers on the head. If someone has changed that tier, so say from red to yellow, how would you change it if you've marked them on your head? So if you wrote down D for dead or I for immediate, how would you change that if they've also changed?
if you have some hand sanitizer or some alcohol, rub it off. or water, something those are usually permanent. So probably in the worst case scenario, rub it out and write it again, write it again. Whatever you can do to make that so that everybody can figure that out. Okay, so remember the 2 things that you can do to treat a patient. Adjust the airway and try to stop bleeding. Okay. Stop, look, listen, and think. Thinking is kind of hard to do sometimes in these situations, but thinking is an important part of this. So, you get in there and all these people are screaming and crying and they're scared, and you're just trying to find out. You saw that firefighter, how calm he was. Of course, he's done this many times, but and if you haven't done it, this is your first time, you're going to be, your heart's going to be pumping like that. Just try and calm yourself down, and you can keep them calm if you feel calm. And just remember, oh yeah, 32 can do. 32 can do. That's what I'm going to do. And just go from there. Verbal triage, remember the leader's going to do that. And then start where you stand, do it systematically. I've seen teams go in there and I explain to them, decide which way you're going to go, and they just go, they just pick somebody. And here's another thing that I've noticed, kids will hide. So check everything. If you're in a room like we have here that you can't see, sorry, I'm pointing to it. There's cabinets, and kids will hide in cabinets, or they'll hide in under beds or something like that. And the reason they do that is because if they can't see the bad person or the bad thing that's happening, it's probably not happening. So they try and get away from it. So check everywhere, even if it seems, impossible to get into. It might be a small child that's in there. And that's another thing when children are with mothers and something happens to the child. It's like a baby and the mother won't leave the baby's dead. That's the only time I think I'd take a deceased person out, is if the mother won't leave without the child. But other than that, you would leave the deceased. Yes, all victims are tagged no matter what, and we do change the tag if their situation changes. Document. And
Let's talk a little bit about how a couple of ways, or at least one good way to document, because you're moving through people very quickly. How are you going to remember how many reds and how many you had?
so you have your tag, and you pull off down to the delayed and the person's immediate. Stick this part in your pocket, and then you know that you have the one above, that's what you have. Or if you have triage tape and you tag this person red, pull off.
Go ahead and tag me.
Okay.
Go ahead and want to tag me red.
This is your clue. Stick that in your pocket. You have this many reds, this many little pieces of green tape, this many pieces of yellow tape. So then when you get out there, you know how many of each you have. Or if you don't have either of those, another thing you should put in your backpack is a roll of medical tape. Put a piece of medical tape, you can't see down here, but you put it on tape it on your leg, on your pants. When with your Sharpie, you write on immediate and write I, and then you just put score marks.
Move forward in the slide. Move forward in the slide. There might be a basic.
This isn't just a.
So yeah, so that's a sample. So you would write, you would write IDM or dead on your tape on the thigh of your leg, the way Pauline just described, and then you just do a hash mark every time you come across somebody who's an immediate, delayed, and minor, right? And then when you walk out, you just look at your tape and you go, okay, I've got this many minors, this many delayed this many immediates, right? And then you've got, and again, your leader is reporting that up to your command post. You're keeping your command post up to date.
Right.
Okay, Pauline, question for you and Sandra. There is someone who is raising their hand, and I don't believe they have the ability to chat. Would you like me to unmute them so they can ask their question, or would you like me to follow up them after?
No, sure.
Okay. So Donna, I'm going to allow you to talk. So if you want to ask your question, you have the ability to as of now. So we'll see. It could also be a mistype, but she has had her hand raised for the past few minutes.
I think I asked that question about the marker.
Okay, perfect. Okay, thank you, Donna.
I'm sorry, I didn't know I hit the button.
All good. Just wanted to make sure. Thank you.
Thank you so much.
I've been in a lot of meetings where somebody said, I hadn't raised my hand. So, yeah. So this is the victim data form. And in our trailers, we have all these forms, and you will probably see them at our skills day when we have it. And so this is an easy way to document what is going on with each of your victims. Here's another one. This one's filled out. So you can see what time they came in, what they were sorted at to begin with, what their respirations were. Respirations, how fast they're breathing. The Blanche test, what that came out when you did it. If you feel a pulse, is it strong? Is it weak? Can you barely find it? And it'd probably be a good idea to find out where that pulse was taken, because yeah, it's just a good idea. But if you can, wherever you can. And are they alert or are they confused? That's a real important one.
But where are you filling these out at?
At the
Medical
at the
treatment.
medical treatment area. And yeah, anything else that you can tell. And okay. Here's the victim treatment area record. This is at the medical treatment area also. And sometimes you don't know the name of the patient. Yeah, I mean, a lot of times if they're confused, they either can't tell you or they don't remember, and there's nobody there with them who knows them. So red shirt, jeans, pink shoes, anything, red hair, anything that is different for them, so that they can be the people who are their family and friends can find them if they have a description of them. Here's another one that's filled out. So they know this guy's name. So they were able to put his name down there. He was triaged as immediate. And this is what his problem was. He was bleeding heavily on it from his head. And he was very dizzy. I would be dizzy too. And where they took him to and what time, so that his family and friends can find him. Medical treatment area, you don't want to put it on a hill. You don't want to put it near a river that might overflow. Just look around and see what a good area is, someplace where ambulances can get in, so that they can pick up a patient quickly and get them into the ambulance and not have to carry them a long distance. You want someplace that's maybe sheltered, if you can find that. That's not always available, but if you can, you will. You don't want to be on a hill, and you want to be away from the wind if you can. So if you can have a grove of trees and it's blocking the wind, that's a good place to put it. So just take a look around. A lot of, I know the San Mateo ones, a lot of them are in parks. Of our medical treatment areas are in parks. And that's a good place because there's grass and it's pretty flat, and it's a good open area where ambulances can come up and pick up patients. So we always put these are the tarps that Casey was talking about. So they're all laid out together in the treatment area, and you notice that there's one over to the side because we want to separate anybody who's deceased from the others because they don't, it's just depressing, and we don't want other people to get upset if at all possible. So we keep them to the side. And like I said before, that is for the people who die in the immediate area, and then move them over to the morgue area. Oh, this is a poll.
No, there you go.
All right. So I wanted to be sure to discuss this. I wanted to first of all ask the question. So this is, imagine yourself at a multiple casualty incident.
Wait, Sandra, do you want me to stop the poll then and restart it?
No, I wanted the poll first and then we'll discuss.
Okay.
Thank you though. And yes, you can pick more than one answer. So I know people are reading the answers and going through. Okay, so the options are, so the question is, if I'm trained in CPR and I start to administer CPR to someone, when can I stop? When professional responders are with the victim and take over, when I am too exhausted to continue, after I've talked to 911 and I know professionals are on their way, when the victim revives and starts breathing on his or her own. So a couple more seconds here, folks. There's only a few of you. There we go. All right, so the overwhelming answer for most people is when the victim revives and is breathing on his or her own. Excellent. I would stop at that point. They probably would appreciate it if you stopped. Second place came in when professional responders are with the victim and take over. When I am too exhausted to continue, and after I've talked to 911. The only one that I would eliminate from that option is when I know professionals are on their way. They're not there yet. So let's discuss CPR in the world of CERT. CPR is not a CERT skill, although I encourage, and many of our CERTs are CPR trained and first aid trained. CPR is not a CERT skill because when you're in CERT and you're working as a CERT, you're working as a team. When you start CPR on someone, once you've made that commitment to start CPR, you don't stop. You don't stop until professionals are physically there and take over from you. You are too exhausted to continue and you just can't anymore. And or if the victim is revived. Those are the only situations in which you'd stop. It is physically exhausting. CPR is physically exhausting. And it takes a lot to do it properly for an extended period of time. And even the most in shape person won't be able to do it for more than 25, 30 minutes max, even with all the adrenaline and everything going. Okay?
Not effectively.
Effectively. I'm talking effective. You know, there's an effective point with CPR. So I do encourage you to take CPR, but CPR is not a CERT skill, and you wouldn't be using it in a mass casualty disaster situation, because if you devote yourself to that one person, you've decided to do CPR, you've taken a person out of the team of 3, you're no longer a team, that team is no longer able to function. So let's say you're a medical professional and you come across somebody who needs some sort of procedure, and you're able to do that procedure because you are medically trained. If you decide to devote yourself to that person, you now cease to become CERT. You take your vest off. You're no longer CERT. You are a doctor doing a medical procedure, and your team now has to go back to the command post and reassess or reform another team. That's fine. I'm not criticizing. I'm only saying that's the decision you've made. So the plan needs to be made before you, when you're assessing your plan and you're making your plan and deciding when to go in, and that plan could take a week. That plan can take 30 seconds, right? Depending on the situation. But if you, as a medical professional or as a CPR trained person, decide to make that commitment and decision, you have taken your team out of commission. All right. And the CPR, like I said, 911 is not coming quickly. So you may have missed out on saving 3 other lives and lost the person that you committed to. This is not in a normal day-to-day situation. If you're in your office and your coworker collapses, obviously you're going to devote all your attention to them. You're going to call 911. You're going to start CPR, and the paramedics are going to be there in 4 minutes. Okay, that's our world today, thank goodness. But if we're in a bad situation, regional disaster, decisions have to be made. So triage first, then treat. Triage first, remove victims that need to be removed, and then treat at the treatment center or just outside the area where they're safe. Okay? Again, catastrophic situation.
So yeah, thank you, Sandra, for clarifying, because we did get a question that came in that said, I thought we were supposed to keep with the 30-second rule and not perform CPR.
Correct. So in CERT and in triage, we do not do CPR. We don't even do general first aid, right? We would be moving very quickly, 30 seconds, triaging everybody, sorting everybody, then moving them out, then treating them, right? In order to be effective, in order to make difficult decisions in a difficult situation, and to do the most good for the most people, because that's what we're trying to do. All right. Not easy. I'm not saying this is easy, and I'm not going to criticize you if you decide to go a different direction. I'm only saying these are the decisions, and triage is a system that helps you make that decision. I've lost my cursor. There we go. All right. So things that can go wrong. Why would it go wrong in triage? So planning is always necessary, right? Have a plan. After you size everything up, you have a plan, your team goes to the plan. Like Pauline said, let's say you're going to that community center. There's been a collapse in one room where the party was going on. So you know you have multiple victims. The power's probably out. It's dark. People are crying, yelling. It's dusty. You have to keep in mind that things might continue to fall. And again, that's what the leader's at the door for, looking to see if there's anything that might hurt his or her team, right? Keeping an eye out for anything that might change. If something starts to change, you're pulling your team out. Yes, you're leaving behind the victims. Pull out so you can reassess and go back in when it's safe to do so, right? Because you're not going to do anybody any good if you're staying someplace where things can collapse and now you've added to the victims, okay? So follow your plan, always reassess, make sure the plan is working. If the plan isn't working, step back and start over, right? And then document, okay? The pitfalls are things of no team plan, everybody just ran in willy-nilly. Leadership was not clear. One focus on one injury. Usually the person who's screaming the loudest tends to get all the attention, while that quiet person in the corner may be the one that just needs their airway adjusted and bingo, she's going to be fine. But this person is obviously fine because they're breathing and they're talking and screaming. They're fine. I know it sounds harmless, but I used to be a lifeguard. And one of the things they always ingrained in us as lifeguards in our training was the last thing you want to do is get in the water. Remember, you're a lifeguard at a pool. The last thing we do is get in the water. So if someone comes up, screaming and sputtering and splashing, right? What do we try to do? Get a pole, get a towel, get something to pull them in with. Don't dive in, because that person in a panic is remarkably strong. And even the best swimmer would have difficulty if they get a hold of you trying to stay above water, because they're trying to push you down to stay up. They're in a panic situation. So last thing a lifeguard will do, in a pool anyway, is go in. They will try to avoid going in at all costs. Okay, you don't want to make yourself a victim. If you're at a lake, you can use a cooler. Coolers float. Keep something between you and the person who's drowning and floundering. Okay, they can grab onto the other side of the cooler and you can drag them in, or the towel. Right? Keep some distance between you and the person who's in a panic situation, is not thinking about anything other than staying above water. All right, same thing here. Keep yourself safe. Make sure you have the tools. One example that Pat Halloran has given to me before was, if you think about the YouTube shooting in San Bruno a couple of years ago, that first came in as a fire alarm. So fire arrived just before law enforcement did. Well, when fire arrived, they realized this is an active shooter situation. Fire doesn't have the tools to handle an active shooter situation. So they waited another second for the police to arrive and let them go in, because they had the tools to deal with it. And then they went in right behind to handle the victims and treat the people who needed the help. Again, you have to have the tools to deal with the situation. All right. We've talked about disaster psychology. You took that unit already. Not every injury is visible. And of course, internal bleeding doesn't qualify under mental health, but the mental health part is also very important, as we talked about with shock and the mentality of the person. But taking care of yourself and your team is vital. The most important person is you and your team. We want to keep you healthy. We want to keep you safe. We want to keep you from harm, but we also want to keep you emotionally healthy and mentally healthy. And in a disaster, we tend to overwork too long. We don't sleep very well. We forget to eat. We forget to hydrate. So especially if you're a team leader, but you've got to try to remember, even for yourself, you've got to make sure your team gets a break, make sure your team hydrates, make sure they eat, make sure they rest. And as a CERT leader, if you're at the command post, try to rotate your teams out when you have a chance. Right? We're, as CERT, you're volunteers. We're not going to be treating you the way we would treat our professional responders. And in the case of our professional responders, we're also making sure they rotate out, make sure they get something to drink, make sure they eat something to eat, and they're able to get away from the scene a little bit, because you've got to clear your head. You've got to get away from that for a while. Any other questions right now for me or Pauline? How are we on time? Triage is by far the most difficult thing to get your head around. Don't worry. This is not the first time you're going to see it. I wanted to talk to you a little bit about what Skills Day is going to look like. In the past, we've had volunteers be victims, and we have great moulage artists, which are people who know how to make it look like you have a bone sticking out of your arm, or bruising, or blood coming. It's terrific. It's theatrical. It's a lot of fun. The kids who get moulage love to go out in public afterwards to freak people out. But unfortunately, because of the pandemic, we won't be able to do that for the next few Skills Days. So the Skills Day for you, when we are able to do it, the victims are going to be mannequins. So obviously they're not going to respond, and they're not going to have a pulse, and they're not going to have any of the things that are going to happen. But I wanted to show you what it might look like. So we're going to move the camera, and I'm going to stop sharing for a second so that you can see. And you'll remember Bob. So I'm moving the camera, so be careful, people. Don't get dizzy. You see Bob? So you would come across Bob. He might be underneath a table, or he might be under a piece of wood or something, right? And he is obviously out. But how do you know what Bob's situation is? So see that card that Pauline is holding up for you? All of our mannequins are going to have a situation card like that one. And it'll tell us, so read that one to us nice and loud so we can hear.
Open fracture on leg, 41-year-old female. This is Bob.
This is Bob. But Bob is a female. So, come on. You have to be open to everything right now.
With leg open fracture, respiration rate 24, capillary refill less than 2 seconds, conscious and oriented.
Okay, so Bob is conscious and oriented. So what do you think we would, how would we classify Bob?
Well, first of all,
Or
his
Bobette?
his respiration rate is 24, so that's good. His cap refill is under 2 seconds, so that's good. He's conscious and oriented, so that's good.
That's good.
But he can't walk.
He can't walk.
So I would label him delayed.
Okay. So we would put a yellow tag, yellow ribbon, or we would write D on his forehead and put him out on the, we'd have to carry him in some way, and we'll talk about lifts and carries in the future, and get him to the medical treatment area. Okay. How do we know where the medical treatment area is? Any ideas? Hang on, I'm trying to share again. That's why you're in touch with your command post, right? And you're saying, okay, this is our situation. We have a mass casualty incident. We have, 10 immediates, 12 delayed, 16 minor, that sort of thing. So now the folks back at your command post are saying, oh, we're going to need a medical treatment area in the vicinity of where this incident happened. So then they would send a team out to set that up. If we have the tarps, we will put out the tarps. If we don't have tarps, we'll just mark it on with chalk or whatever. We'll make an agreement that this will be the immediate, this will be the delayed section, this will be the minor section, etc. Okay. You make do with what you have. If you don't have the tools to deal with a situation, you may have to skip that and move to something else. But again, in a perfect world, you'll have enough people to set up. One team will deal with the medical treatment area. One team will deal with the triage. One other team may deal with transportation of the victims, and so on. Okay.
So Sandra, we do have a few questions if you're ready.
Yeah.
Someone's asking if you can go back to the slide regarding assumptions for CERT Ed. Need to complete how survivors will assist. Does that make sense, or do you need me to ask them for clarification?
They want to go back to which slide again? I'm sorry.
Assumptions for CERT Ed.
Assumptions for, is that like at the, I think that was way at the beginning, the assumptions part. Sorry, as we swing back to.
Yeah, I just saw the assumptions there.
There.
Okay, there you go. Okay.
Is this the slide they wanted? So in this case, as I was saying, at training, in training, we have to make certain assumptions, right? So for example, on skills day, that's your training day. You have to assume that the mannequin is a real person and the card will tell you what the issue is. In real life, maybe that person could tell you themselves. Maybe that person would be unconscious and would obviously be showing signs of trauma, and you'd be able to deduce what the situation is based on those signs and symptoms, right? But since we're going to be working with mannequins, the cards are going to be what you work. So assumptions have to be made when we're doing training. So in this case, we are talking about triage. Triage is in the case when we assume that there's going to be more victims than there are rescuers. Does that make sense?
Okay, and we got two more. So we said, someone's saying, I'm confused about IS 315A. I've clicked on the link, but I'm lost after that. And they're asking to review that at the end, which I believe is now, so.
Okay. So IS 315A is a FEMA online course. So there's two things that you have to do. Well, one thing you have to do prior to that is you need to get a student ID number from FEMA. So there's a process there. You should have that information in the how-to, if you will, how to take the IS 315A. If you want to email me specifically, I'll be happy to walk you through it. I just don't know where you got stuck. So you'll need two things. You can go through the course, but once you want to take the final exam, you'll need that student ID in order for you to get credit for having taken that course. Think of the 315A as a separate course from Online CERT because it's not attached. This FEMA course is not attached to Online CERT. It is one of the trainings that we do. So it's going to be set up differently. It's going to look different. and you're taking it through FEMA's Emergency Management Institute, their college training, if you will, online. So by all means, email me directly at cert@smcfire.com. Casey can put that in the chat box there for you, and I will walk you through it.
And while I'm doing that, we have a few more that came in. So someone's asking, where can they get their score percentage for the IS-315A test? And I can help out with this one, Sandra. With the FEMA courses, it's a pass-fail basically. So you need to get, I believe it's 65%. So it would either tell you passed the course or haven't passed the course.
Right.
Is that correct?
You can go back and take it again. It's just a matter of, unfortunately, yes, pass fail.
Yeah. Okay. So someone's saying 75. I thought it was 65, but
I think it's. I was going to say 70. So somewhere in there, but I think it's at least 70%. Yes.
And we got a few more as well in the chat. So 1 second. Someone is asking, they don't have a printer. Can they pick up the forms? I'm not sure what forms they're regarding, but
Oh, are you talking? You're probably talking about the CERT forms. So such as the medical treatment area forms that people fill out, or the victim treatment, the victim forms. So these are all CERT forms that are available on our website. A lot of our CERT members keep a couple of these blank forms in their backpacks. And we'll talk about which forms are the ones that you're going to most realistically be using yourself. And the ones that are, we have medical bags, for example, in the trailers, and in the medical bags, we have these forms. So when a medical treatment area is officially set up and we have the trailers available, we'll have the forms. If you don't have the forms, you're going to use binder paper, notepad paper. So you always want to have that in your backpack. And when you're first documenting, like we talked with Pauline, you'll either have tape on your thigh, your pants, or you're going to have pieces of triage tape in your pockets, and that's going to tell you how many victims you had and what category they fall into. You've not taken names, you've not taken, gender, you've not taken any information at that point. At this point, you're just triaging them and saying how many reds, how many yellows, how many greens, and how many black, right? And then at that point, you know how many people need to be moved out in what order. And that's when you get the other team to help you with the transportation of victims. And then at the medical treatment area, that's when they spend the most time treating them. We're running late already.
Clarification, they're saying the forms found within the rose-colored box on the CERT page would leave there. And so if they don't have a printer, how can they get them to you? It's
the DSW, the hold harmless, any parent permission forms if you're under 18. So make sure you save those digitally. Chances are, and I'm going to tell you right off the bat, you are going to eventually be emailing those to me. But the DSW form has to be signed in ink by you. It cannot be done digitally. So that one is going to have to be printed out. Don't worry, we'll find a way. If you don't have a printer, we'll get access to one prior to Skills Day. Okay.
And if as a option too, we may also have the ability to bring them and do them there if needed.
Yeah, that too. Absolutely.
So there's a question that I don't know what it's in regarding to. It was a few minutes ago. So it says, team leader should guide them there, right? So I'm sorry, I don't have context around that one, Sandra, but hopefully you know what that means.
Okay, the team leader should guide them there. Okay, so the team leader, let's picture that you've arrived at your command post and there's 6 of you plus, maybe 2 more people. So the 2 people will probably stay at the command post. They have radios. They have maybe they're the first one who arrived, they're the one who organized the command post. They assign 2 teams of 3, and the 2 teams are sent out on a particular mission. In those teams of 3, you need to decide who's going to be the leader, who's going to be the scribe, and who's going to be I just forgot the 3rd position. Okay, my bad. I apologize. That doesn't mean that's all you do. The scribe is not just going to be writing, okay? The leader is not just going to be standing there giving orders, right? Everyone is the safety officer. Everybody's keeping an eye out on each other, okay? But at least if you have somebody who has a ham radio license, for example, or has a walkie-talkie, they're able to communicate back to the ICP. They may decide, okay, wait, I got to go deal with triage, so I'm going to give my radio to the leader who's staying at the door, and he or she can then report in as to what they're finding, what their needs may be, if things are changing, that sort of thing. The person at the door can be taking notes. Hey, I got an immediate here. I got, one person, with a broken leg. I got, what, and then that person can at least start taking notes, and they can compare and make sure they got the same number of victims and how many are in each category. So yes, there has to be a leader who makes the final decision for the team and is in charge of keeping the team safe, but that person's role may also include taking notes, or may also include using the radio and communicating with the command post. Okay, everybody has to do a little bit of everything, but you will pick a team leader from your three.
No, I think they clarified a bit. So would the team leader be guiding others to the treatment area?
So the team leader, depends on what your assignment was. If you're the ones doing triage, you're the ones at the bus, for example, and now you know how many victims you have, then they would communicate that to the command post, and the command post would say, we're setting up a medical treatment area. This is where it's at. And so now that person knows where it's going to be, and hopefully we'll get assistance from another team to come in, and then we'll direct, let's get the immediates out first, and you're passing them on to this team, and this team will get them to the medical treatment area. So technically, whoever has the radio and is in communications will let the leader know where things are or how things are going. That might be the leader in this case.
For those who may need printing options, someone suggested printing at the library, and I included a link in there. But again, we'll get you there. No worries, as Sandra likes to say. But yeah, so if there's any other questions, feel free to post them.
No, but I'm going to start wrapping it up. T-shirts are available for order if you want to go to the CERT store. I think I sent you the link for that. And for next Thursday, we're doing Unit 6, which is a two-parter, 6.1, 6.2. Unit 6, it deals with fire safety and utilities. And the resources for that are under Class 5. Don't get confused. Next week's class is Class 5. All right, you guys are doing terrifically. Don't hesitate to email me if you have any specific questions. I'll help you walk through it. And I really appreciate Pauline for coming these last 2 weeks and helping us out. You guys are doing very well. Keep up the great work. And thank you so much for joining us tonight. Be safe, and we'll see you next week. Take care.